guys, welcome back to the show today. And today I want to talk about how to open up tight joints without surgery or injections. And these are natural ways to improve your joint flexibility for those of you that are over 40. Now, there are two types of motion that I'm going to go over today, and this motion actually provides you with the capacity to move. One of them you can partially control on your own, and the other one requires a specialist who has the skill and education to open up space in the joint. And today I want to break down both of these types of motion and answer the question, how do I open up tight joints naturally without surgery when I'm over 40? And I want to talk about what causes you to lose this motion. So lost motion in a joint first sends signals, and you lose this motion in the joint. And once you lose this motion through what we call restriction, then your muscles tighten and hold. And this is the most simple way to understand a very complex process, okay? Your body actually restricts the movement, and that's the movement of the bones inside the joint capsule. Your muscles respond and start holding, and this is what you're feeling. This is your tightness, your stiffness, and your soreness. And after this, many other things begin to happen, all without your knowledge. It's all silently. But you feel the effects of all of this at some point, and there are signals that help us to understand this. And I'm pretty excited to be able to share this with you so that I can also start sharing some signals so that you can change that typical reaction of, hey, I'm going to seek care after I'm in pain. And today I hope this will help you understand what's going on, why you experience pain, and how you can actually open up this space. So we're going to start with two types of motion. We have accessory motion. This is found inside the joint. And then we have physiological motion. Now, most of us are familiar with physiological motion, and this is our range of motion. This range of motion is controlled by our larger muscles, and these larger muscles, their role in movement are to move your joints, okay? We can build strength and mass in these muscles, and this is the layer of our movement system that we can control. Well, I guess I should say we can partly control this layer. There are outside and inside forces that control this layer beyond what we can control. But for most of us, we build strength, mass, flexibility, and we do all of that through looking at the muscles, the larger muscles. And we stretch these muscles, we strengthen these muscles, we can build mass in these muscles. We can keep these muscles flexible to a point. So range of motion is the ability to move our muscles through a specific direction, and this measure combines the motion of the muscle, the fascia, the tendon, the ligaments, and the joint. And we measure this motion in degrees using a goniometer. Range of motion can be performed actively, it can be performed active assisted or passive. Now, active range of motion is the range in which we can move our joints through a specific range, usually ranges or planes of motion. Examples of this are like flexion, extension, abduction, adduction, and rotational planes of movement. An example of active range of motion is you raising your arm up above your head, or maybe you moving your leg out to the side when you're in a standing position. That's hip abduction. Now, examples of active assisted range of motion, this is harder to describe, and it requires assistance from someone else to assist you in performing this motion. Now, this range of motion is used mostly in rehab type settings where people have lost range of motion in a limb, and they require assistance or neuromuscular rehab to assist in the movement to rehabilitate that limb so that they gain more range of motion. And then the other range of motion is passive range of motion. Now, this is when a professional moves your limb for you while you relax that limb. Now, passive range of motion is typically measured by rehab professionals as a tool to see how much range of motion your joint, your muscles, tendons, ligaments can move passively. Now, these professionals measure this range using a goniometer, and this measurement has industry standard normative values associated with every joint movement of the body. To use an example, your shoulder moving into flexion should have 180 degrees of range of motion. When it is measured passively, that is considered within normal. And that's what your therapist is going to document for your doctor or your insurance company to justify your PT treatment. Now, range of motion is measured and compared to standard measures for active, active-assisted, and passive motions. Active, assisted, and passive range of motion, these are also used as techniques to improve your range of motion. In rehab, your PT or your PTA may stretch you passively to increase your passive range of motion in a limb that has lost passive or active range of motion. A stretch therapist is going to use active, assisted, and passive stretching along with other techniques like contract, relax, and some other ones. And they use these to stretch your muscles deeper than what you can stretch yourself. And this is also known in PT as passive range of motion. Now, in the PT realm, passive range of motion and active assisted range of motion, it's done to rehab a limb. In the assisted stretching world, it's marketed as stretching. Both of these stretch soft tissue, which is a muscle, and they both do it deeper than you can stretch yourself to allow for more range of motion. You cannot perform passive or active assisted range of motion on yourself. A professional must move your limb using these particular techniques. Now, just a little history. I worked in physical therapy as a PTA for over 25 years, and I opened my own PT practice after being in the field for 14 years. And I felt like I was not giving people what they were expecting as an outcome. I also saw my clients always end up in a surgery. And, we didn't really track these outcomes, but people would come back time after time. And it's like, instead of me seeing them get better when they came back, I saw them going from walking normally to just having a hip replacement. And it's like, oh my goodness, what's happening with these people? We discharged them and they were doing great. Now, I saw the transition from passive range of motion to assisted stretching centers popping up everywhere. Therapists at the time were pretty much offended that stretching centers were using non-skilled or licensed people to actually stretch people. But now, as insurance reimbursement goes down and assisted stretching goes up, it's pretty cool to see the demand that you see PT clinics and chiro clinics picking up to offer stretching, PT, and recovery sessions to help people, because this is what's making PT clinics more profitable. They're jumping on that bandwagon. Now, I myself opened a PT and wellness studio back in 2013, and I thought at that time, if I had more time with people to stretch them and strengthen them, I could help them move better. What I found later was not exactly that, but I did start there over 14 years ago, and I am in a totally different place now. And it's pretty cool, the place that I am in. In fact, it is that our everyday lives require range of motion to allow movement. And movement itself is very, very complex. And quite so, because our bodies are complex. Now, range of motion is a standard measure and standard treatment across various providers around the globe. And these providers help us manage and preserve the strength, muscle mass, and flexibility in our muscles, tendons, ligaments, and our joints. But this is where it gets a little confusing for all of us, providers and people alike. Range of motion is combined motion in a certain plane of movement, and it can be measured, but it's mostly measured in rehab settings after an acute or chronic pain or injury. It's also measured in pre and post surgery, or when someone has already been diagnosed with a disease. It is passive range of motion that allows a PT to stretch the soft tissue to make range of motion gains in a certain plane of movement. Now, soft tissue refers to the muscle. So the PT or the assisted stretch therapist or coach, they stretch your soft tissue, which are your muscles. And when this is performed, you can see an increase in your range of motion. Other techniques add the instant length results in the tissue. Some examples of those are contract relax techniques, PNF, fascial or myofascial stretching. All of these techniques work to improve your range of motion instantly. Now, remember, your range of motion is the complete measure of the muscle, the tendon, the joint, the fascia, and the ligaments all together. It's a combined measure. The caveat here is that range of motion allows your body to compensate. And compensation is another important factor that I'm going to get into a little bit further in the show. Here are questions that I ask myself. So when I look at this range of motion measure, is this measurement the go-to measure for longevity? For those of us that are looking to be able to move well, reduce our risk of falls, reduce surgeries, and possibly, up until that last day of life, be able to do what we want to be able to do. And this range of motion measure is a combined measure of joint, muscle, tendons, fascia, and ligaments. It doesn't isolate the source of the loss of motion in the joint. And this is what I would like to break down so that you can see what you're getting when you pay for different services and what maybe you assume you are getting with these services, because there is a lot of confusion around this. Now, your larger muscles move your joint, and that's their main role. We can keep a muscle strong and still have limited range of motion. As I mentioned before, this combined measure, this range of motion, it doesn't measure actual joint motion. And that's the second motion I want to talk about here. And that is the accessory motion that I told you about in the beginning of today's show. This combined measure, range of motion, measures everything as one score, and it does not at all measure or isolate your accessory motion. And it's this motion, this accessory motion, that is outside of our voluntary control. And that motion is what allows us to restore and preserve our range of motion. So range of motion, we have some control over through strengthening, stretching, through passive range of motion, through assisted stretching, okay? We can all stretch out the muscle. You get some stretch in the tendon, the ligaments, the fascia, also a little bit in the joint. But you don't get true joint accessory motion change with those techniques. So this second motion is not offered at scale like physiological motion is, okay? You have stretch labs all over the place. You have all types of other stretching centers. You have PT. You have PT now offering stretching. This is offered at scale. And this is where I think we need to scale things. We need to be able to offer this at scale. And this is what I want to dig into today. This second motion, this involuntary motion that we have zero control over, okay? The body takes it from us through different things. And it's not just one thing. It's very confusing. It's very complex. And it happens silently. And this motion is found inside your joint capsule. And this motion is not readily available to you, meaning you can't stretch it, you can't strengthen it, you can't foam roll it, any of that. This accessory motion is the motion where you have two bones inside a joint capsule and it is not under your voluntary control. It's also the most complex and the most misunderstood motion in the body. You can't move it without someone. It is not your range of motion. They are not the same. There is no single muscle that performs it, and you can't decide to just glide this accessory motion in your joints, okay? You can't stretch it. Stretching actually pulls on the tissue around the joint. That's the muscle. It doesn't reach between the surfaces at the joint level. And you can't strengthen it because it's not a muscle. And what it responds to is an outside force. Something has to move that bone and that joint for you, and it's the only way this motion changes. Just like you need a stretch therapist to stretch your muscles and a PT to do to do passive range of motion, This accessory motion, there's certain techniques that actually help you gain this particular motion, okay? And when you start losing this accessory motion, there's no signal, there's no pain, there's no pop, there's no moment that you know that it's happening. It simply is restricted and your body begins adapting around it with this compensation. And that compensation is not truly understood either. And it's also not tracked. And that's kind of crazy to me. This is what makes movement health so complex to understand and to control, because we have all of these great tools out there for us, all of these great specialists, but none of them can get to this accessory movement, and we don't have it bioavailable to us at scale. Now, I call this accessory motion involuntary motion because that's what it is. You can't change it with your own through any exercise or mobility drills or through walking. It has to be restored and then preserved if you want to keep it. And that means you need someone to test it and restore it in order to preserve it. Now, just like assisted stretching or passive range of motion, you can't open the joint accessory motion yourself. Many people market, you can open it through like self-mobilization. You'll see that all over the internet. Go do this self-mob. But I didn't find any research to support that. In fact, a self-mob is performed actively. So I speculate that it's more of an active mobilization when passive joint work is the only thing that actually opens this available accessory motion. Now, in my PT clinic, I've got a story for you. Stacy, she was my PT, and Stacy's now out on her own, and Stacy and I are really good friends, and I actually go see Stacy because she can open up the available space in my joints, and all of us need this. So Stacy is a PT, and she at my clinic worked for me for several years, and we would banter back and forth in the office. Now, I was a PTA. I knew my passive range of motion. I knew my soft tissue skills and my modality skill. And she had extra training in the joint itself. And I remember stretching people, and she would joke me and say, "Go ahead, you can work harder." And but then she would also say, "I'm going to be over here and I'm going to address this accessory motion in the joint, which is the major communicator between the muscle and the brain. And this is going to loosen faster without me having to work hard, and you're going to spend 45 or 50 minutes stretching somebody, and you may or may not get the same effect that I got." Now, she's the person that taught me to start looking at the joint. In fact, those skills PT use for the joints are called joint mobilization. So PTs specifically are trained in joint mobilizations, and those can effectively open accessory motion in some directions. And this is an effective PT tool. Chiros do this with adjustments, and then doctors of osteopathic medicine do it through manipulation. The point I want to make here is that accessory motion is what controls your range of motion. And the research connects this. PTs use joint mobilization and joint manipulation. Chiropractors use adjustments, and doctors of osteopathic medicine use manipulation. And from what I found in my research, all of these treatments are used at scale post-pain, but I couldn't find a study stating that these are used non-symptomatically in people utilizing these treatments, except for in the chiropractic literature. I did see some post-symptomatic chiropractic maintenance reported to help decrease repeat pain symptoms. I would love to see a study on asymptomatic people. Those are people who don't have pain. That exactly would be interesting to me. Most of us want something that they can do on their own. Most of us want a DIY. We want to be able to stretch. We want to be able to strengthen our muscles. We don't want to have to rely on a provider to do something. But as we're getting older and as we see our mobility decreasing, we are seeing that we're going to have more providers. And I think we're going to see a pretty big growth in these areas. But based on my research on this accessory motion, you don't have the ability to control accessory motion, as it requires a skilled professional to open that space for the bones to move. And I don't have research that shows that the accessory motion is maintained over time. And I mean years. Now, what I do have is in my studio where I actually test accessory motion in every client that comes in to see me. And I see the joints restricting in between sessions. But for the people that have received care over years with me and have both good deep stability, good strength, and their deep muscles are actively firing, these people actually maintain large muscle strength. They have maintained their muscle mass over years, which is pretty interesting because the statistics show that after 60, we lose way more, but my people aren't losing this muscle mass. But I don't have anything except for the small amount of people that I follow. My people are also following muscle building nutrition, and I do see those people with less restrictions over time. But also, one joint can lock down, it can lose its accessory motion. And it's interesting that with what I teach, my clients know their signals, and they get in to see me pretty quickly to open that accessory motion back up. Now, my model is different than other models because I work with a person longer. Many of my clients have been working with me for greater than 5 years, and the results that I see in those clients is where I see improved accessory motion over time. I also see improved range of motion. Now, my model teaches 5 drivers of healthy movement, and my clients live by those 5 drivers. So I have seen long-term holding with monthly sessions. Some of my clients come in 1 time a month, some come twice a month, and some come weekly. All of it depends on what they're looking to achieve and how fast their body locks down and restricts movement. It's also based on many, many other factors. Now, from what I see with my clients, DIY programs always end up in a symptom or diagnosis from the people that I have seen and follow. Now, guys, this isn't from a study. It's just from when I see people when they stop care because their pain is gone, and then they return with pain after seeing their doctor. People always want a way to do it themselves. It's cheaper, it's more cost effective. But guys, I haven't found a way to teach that. And these techniques that actually get to the accessory motion, they have to be performed by a professional so that they're performed safely, they're effective, and that they are targeting the outcome to improve range of motion through improving accessory motion, which is associated with the loss of range of motion. Now, a PT, again, does joint mobilization and joint manipulation. A chiropractor is going to do an adjustment, and a doctor of osteopathic medicine is going to do a manipulation. My techniques are much more gentle than that, and I focus on this accessory motion, but I focus on stretching out the joint capsule so that the bones glide better. And based on what I do with my technique, I actually can see the nervous system protective response decreasing. So we get improved health of the nervous system through taking that protective response down. And then we do a whole lot of other stuff that I won't even bore you with right here. But let's talk about this accessory motion. I want to use an analogy that'll help you better see what's happening in the joint. Okay, I want you to think about a door in your house that no longer opens or closes like it used to. And this door can't open or close completely because the hinge is rusted. And you can pull on that door as hard as you want. And probably you've experienced this at some point in your life. It may open part way and it may stop. And how hard you pull isn't the problem. The actual rust on the hinge is the problem. And the problem is, why is this hinge rusting? And many of you are going to see this more, at your states that have like tropical areas or water. So for those of you who stay with me that are not in those areas, okay, a hinge that doesn't move needs help from the outside. It's not going to just free itself. The rust is not going to just go away one day. The rust is going to keep building. And the longer it stays stuck, the worse that hinge is going to get and the harder it is going to be to close or open that door. So notice what will not fix that door. Doing nothing doesn't fix it, and pulling or pushing harder on it doesn't fix it. Neither one releases the rusting process. It disturbs it, but temporarily, and that's all it does. That's the same reason that stretching a joint or strengthening around a joint does not reach a joint restriction. You can't clean that hinge by pulling on the door, okay? The hinge needs to be fixed. It needs someone to work on it. And this gets a little confusing because you've got stretch practitioners and PTs doing passive range of motion and stretching that actually stretch the muscles, the tendon, and they also say the joint. But you do need to understand that that only gets a partial point of the joint. It does not reach the deeper layer, which is that accessory motion. Now, just like the hinge, your choices are to spray the hinge with WD-40, and you can see if that holds for you. Or have somebody work on that hinge until it frees up and keep working on it if you've got that WD-40 on it. Or you can take the door down, you can clean that hinge until the rust is finally removed, or you can take that door down and you can actually put a new hinge on it. Choosing to leave a rusted hinge rusted will keep that door hard to push and hard to pull. The rust does not go away one day. And it's kind of interesting because, you know, our younger years when we're 20 and maybe 30s, we bounce back from things a little faster. So we start thinking in our 40s and our 50s and 60s, why am I not bouncing back? You know, when I was in my 20s, I hurt myself and I got better. When I'm in my 50s, it's like I just chase symptoms all the time. And guys, that's not just age dependent. There's a lot of other factors going on with that. But we do bounce back earlier because when we're younger, we have all of our muscle mass. We have all of our muscle function. We have our joint function. We haven't lost everything. But as we get older, our muscles are inhibited, our joints are restricted, and they just don't bounce back the way they used to. So you have to have a professional help you in order to maintain that. Somebody has to fix the problem. So when we're back to the door, if you choose to use WD-40 on it, you can spray it, you can hit it with that penetrating oil, and you can hope that it gets deep enough to reach the rust. And sometimes it helps, and often it only reaches the surface. Now you can work on the hinge. Somebody can oil it and then move it back and forth until it frees up, and that oil works its way in. Then it keeps working so the rust doesn't come back. You can also take the hinge off the door. You can scrub that rust off. You can oil it. And that's sort of closer to a procedure like removing a bone spur or cleaning up arthritis, if I have to relate that to anything. Or you can replace the hinge entirely. And that analogy would be like having an elective surgery. And of course, your doctor is not going to say your surgery is elective. That actually wouldn't sell any surgeries. And when we compare a new hinge to a surgical joint, they are not equal. A new hinge does work better, and it actually works close to new. A knee replacement has a ceiling on how far that knee is going to bend or straighten over time. Now, a healthy knee bends to roughly 135 degrees. After a replacement, that goal that gets set in rehabilitation is commonly around 120 degrees. And in one study of nearly 200 knee replacement, that was a 12-month target. Now, there was also a meta-analysis of 17 studies covering more than 1,600 knees that found maximum knee flexion after replacement was not significantly different from the knee range of motion that those people that had a replacement, where that range of motion was before surgery in that symptomatic knee. Now, in the asymptomatic knee, as long as they had all of their range of motion, most people are supposed to be able, in a healthy knee, get to 135 degrees. Now, knee extension, that's the straight of your knee. Those measurements did improve with a replacement, but the knee bend measures did not improve with the replacement for most people. So many people that I've seen post-knee replacement kind of hang out around 90 degrees, and many of them are anywhere from 90 to 95 degrees. And when they're coming in to see me, it's usually because they've lost the range of motion in that knee replacement, and they've lost the range of motion in their hip and their ankles and other places. And by the time somebody gets to a replacement, they've already lost the bend to degenerative changes, and in that joint and in the muscle around it. So the replacement gives us back the motion initially that you walk in with. So you walk in with a symptomatic knee and you've got all of that degeneration and you may have 120 degrees of knee bend. Your replacement is going to give you that much knee bend back. So you're going to lose 15 degrees of range of motion, within a year after a replacement, because you may not even get that 120 degrees back. Many people do, but then they start losing it over time. So you get a new knee without more motion. So a new knee and a new shoulder joint only give you so much motion. You don't get back the joint motion that you were born with. So that is a limitation. And that's if you can get your nervous system and your muscles to allow that much motion in the first place. Many of the people that I see don't, and they can't. And they lose it over time the same way it gets lost in a joint that was never replaced, which tells you, or tells me, what the surgery is actually for, which is pain relief. That is the main reason people choose a replacement, and they're happy they chose that replacement. Many of the people that I ask wonder why they didn't get the replacement sooner, but it all revolved around pain relief. Now they get the relief in that area, but they trade relief for loss of motion in that joint, and that's interesting to see. And there's one more thing I watch happen. They got their knee replaced, but their hip and their ankle are still restricted. And most of those people also have back problems. Nobody tested the joints in the back, the hip, the ankle, and at some point, those joints start sending their own signals and will become symptomatic and painful. And this is a vicious cycle for sure. And we do see this in the literature. We see that, in the literature, we see an increase in surgical procedures after someone has had a surgical procedure. So the answer to this question is yes, you can open up space in your joint. You can improve your range of motion without surgery or injections after 40. So that is the good news. But this is all dependent on the damage, and it can be very complex, and it requires the skill of a professional that understands and focuses care specifically on the outcome that you are looking for. And most people that I have worked with only ask for pain relief. They just want to get out of pain. But over the years, I'm getting more people that are looking for movement and flexibility, and they want to decrease tightness, which I think, of course, is very exciting. Now, the question I ask you when you consider a treatment is, what movement can I expect from this treatment? Or will I only get pain relief from this treatment? And most are going to tell you you're going to have improved range of motion. They're also going to say that you're going to have improved pain relief. So for most of you, you're going to think, great, improved range of motion, improved pain relief. So your next logical question should be, great, how long can I expect to keep that range of motion once treatment stops? And guys, write that down, because you need to know, once you finish treatment, are you going to be able to keep that range of motion once that treatment stops? Now, there was a great study done 25 years ago that I reported in my last week's episode, and that study was on people who already had arthritis. That arthritis showed on an x-ray, and those people had pain. And half of those study participants with arthritis received ultrasound, and all of those went on to have a knee replacement. The cool part of this study is that the other half had PT, and they had manual therapy to the joints of the lumbar spine, to the hips, and the ankles. And of those participants, 5% had a knee replacement, and the others, after a year, maintained their gains made in therapy. And when they said this in the research, they really said they maintained their pain relief. So I don't know if they really maintained the mobility. I'm going to have to go back and look at the study on that. But that was one of the coolest studies that I've seen. And like I said last week, I always wonder that if we test these joints for restrictions in our early years, like our 20s, and we preserve all of this accessory motion that we don't have any voluntary control over in all the joints in our body, okay? And we continue this throughout our life, could we decrease these surgeries? And better yet, can we decrease falls or chronic pain numbers? I speculate that we can, and I'm seeing this inside my facility, okay? And for those of you that do want to move throughout your life, each of these, this accessory motion is going to require a professional that specializes in opening up the space in your joint. You can't do it on your own because it's involuntary. It doesn't matter what you do, you're not going to see that, okay? And if you're out getting stretching or other things, that is not going to hit that accessory motion. Guys, it's also interesting that PT, chiro, and osteopathic doctors learn how to test for restriction in the joints. In school, they are taught this. Some PTs and most chiros and DOs also perform adjustments and manipulations, but it's mostly done on pain population. Except chiro does have maintenance that keeps symptoms at bay. But guys, with all this education, why don't we have this all so much more available to us for non-symptomatic clients at scale, like we have for muscle treatments like stretching, massage, cupping, dry needling and things like that. I speculate that it's because we use pain as a response to seek help. And I hope that one day we'll see that tightness, stiffness, and soreness are much more effective indicators that our joints are in decline. I can also hope that over the next decade, we can see professionals testing joints for restrictions and providing more long-term accessory joint health care younger to see if we can change the current trajectory that we currently see in the research now. Guys, I hope you found all of this information helpful today. I appreciate you joining in today. If you find this helpful, please share this with a friend that is struggling. If they're already out there getting stretching and other things and they're still not getting what they feel like they need, their range of motion is being maintained, but it's not improving, and they don't see the change that they're looking for, or they're symptomatic and they need more mobility and they're losing that mobility, I would love for you to share this information with them. Just share the podcast or just give them my information. And if you're looking for a specialist to improve the joint space, accessory motion in all of your joints, I'm here to help you. I'm excited to see you, and I'm excited to share more about what I do and how I can help you. I'll see you again next week.